Well, let's get started. I am Erica Galvez. I'm the CEO of Manifest MedEx, and I am joined with three really highly esteemed colleagues today to have a conversation about health data utilities. Lisa Bari, who is the CEO of Civitas Networks for Health, is going to talk to us about the HDU framework that the organization has created and kind of level set us around what is a health data utility. Melissa Kotras, who is the CEO of Contexture. For those of you who don't know, that's a health data network that covers both the states of Colorado and Arizona. She is also a member of the Consortium for State and Regional Interoperability. She's going to talk to us about a maturity model that CSRI has created, as well as some of the lessons from her work, essentially as a health data utility across those two states. And then Bill Howard, who is a consultant who many of us have known for many years. He's been working in health IT and interoperability for a very long time, is also a board member of eHealth Exchange, is going to help us wrap our minds around kind of how to think about health data utilities vis-a-vis TEFCA and national networks. And I will try to knit that together for us in the context of California. So to get started, I would be remiss if I didn't tell you a few housekeeping items, and then a little bit about Manifest MedEx. Folks who are joining probably know a number of these things already, but just for the sake of the good, all of your lines are muted currently, and they will remain muted. If you have a question you'd like to submit to any of us on the panel, feel free to do that through the Q&A function at the bottom of your screen. If we have time to get to those, we will. Like I said, I can't promise that we will get to all of them. And last but not least, this is being recorded. We are recording this webinar today so that we can post it online and make it available to anyone who wanted to join but wasn't able to today. So to get started and just level set on Manifest MedEx, we're hosting the conversation today. We are the largest nonprofit health data network in the state of California, with a mission to provide every healthcare organization in the state with the data they need to improve care, enhance health, and lower costs. And we do that today with longitudinal health records for more than 36 million Californians. Those get built from data that's shared across 13 health plans, just over 120 hospitals, and nearly 2,000 providers, plus connections to a wide range of other organizations through national networks like eHealth Exchange. We are hosting this conversation today with my colleagues because California, I think most of us know, has set out an extremely ambitious set of transformative goals for the health and wellness of all Californians. One of the pillars in that goal set is CalAIM. That's our Medicaid program, as many of you know, is focused on delivering whole person care in a way that gives attention to social needs with the same amount of care that we deliver for medical needs. And I think we all have come to appreciate now, being a little ways into that CalAIM program, that requires deep coordination across health plans, across care providers, across community organizations, and social supports. And at a very foundational level, it boils down to data and data infrastructure. And we are fortunate that California has recognized that and has passed legislation through Assembly Bill 133 that requires most healthcare organizations in the state to share data in real time by January 2024. It also introduces the concept of a qualified health information organization. I use the term QHIO to refer to qualified health information organizations. These are essentially data intermediaries that meet a certain level of requirements that are established by the state. The state is in the process of creating that program right now. As that's happening in California, we have the national and federal level evolution of TEFCA, which is the Trusted Exchange Framework and Common Agreement. We also have this concept of health data utilities evolving, and that's the notion that there's data infrastructure, health data infrastructure, that serves the broad needs of stakeholders across the state, not just in the healthcare space, but in the public health space, even extending into the research space. I know when I think about utilities, I think about things like water and electricity, the kind of infrastructure that creates equitable and seamless access to something. In this case, that would be ensuring that a person's health information is accurately matched and consolidated across what is a very fragmented delivery system today, and then made securely available when and where it's needed for permitted purposes and according to individual preferences. That doesn't exist currently in California. And I think one of the big questions we're wrestling with now is, to what extent could that concept either reveal itself or evolve through the QHIO process within the state? And to what extent can we learn from other states that have been successful in establishing this kind of infrastructure? And furthermore, to what extent can that kind of build on or add to national networks? So to get us started, and I'm going to try to keep us on time throughout this, the next 53 minutes, I'm going to hand it over to Lisa Bari to dig us into the Civitas HDU framework.
All right, thanks, Erica, and it's great to be here with all of you. I'm going to try and do a very brief intro of just what Civitas is for all of the folks in the audience, and then do a brief intro as well to the health data utility concept that you really started us off on. I think your opening and your description of what HDU could potentially mean for California is incredibly valid and relevant here as well. So as mentioned, I'm the CEO of Civitas Networks for Health. It's a national nonprofit collaborative organization. We have as members all the folks here in their different capacities, and many other regional and statewide health information exchange organizations, regional health improvement collaboratives, quality improvement organizations, and supporting entities and companies to provide services and software technology for them. So our mission and what we stand for is regional innovation and national impact. We connect all of these folks at the regional and state levels to national work happening around health information exchange and health improvement. Our vision is that communities across the country will be thriving and healthy, realizing the full potential of data-driven, multi-stakeholder and cross-sector approaches to health information exchange and health improvement. I believe you'll have access to all these, so no need to remember them or memorize. You can screenshot if you want, but we'll probably give these to you. This just shows you who we serve. The outside level is all of our different types of members, from data collaboratives and associations to health information exchange organizations, community health improvement organizations, QIOs, and the like. We have members, and they all serve their individual communities in the gray half circle, sort of the community-based organizations, patients, families, communities, payers, plans, Medicaid, public health, the healthcare sector, physicians, clinicians, and staff, hospitals, et cetera. And so that's who we are together between our members and all their work and our programs that connect them across the country. So the broad story, which Erica really started to frame for all of you, is that we have these we have this concept of centralized networks and frameworks. So as Bill will talk about later, the eHealth exchange and the emerging TEFCA national network and private health information exchange networks. And then we have also these community HIE and health improvement organizations. If you look at where we are the last 2 decades of regulation and policy and laws and things that are happening broadly across the country, they really point to this idea of consolidation, centralization, and electronic health record-centric view of interoperability and data exchange. But what we know, and what our members know, and what you'll hear from some of my colleagues here is that these community-governed organizations, the organizations who could be these QHIOs that Erica was talking about that are part of CalAIM, they fulfill really critical roles that exceed and overlap, but also expand beyond the goals of those nationwide or even statewide interoperability networks and frameworks. They're serving their individual local communities. And we really believe, and our members believe, that data governance has to happen at the community level with local stakeholders in line with those state laws and local preferences and connections and different health systems and different people and different structures. And so we really believe strongly and advocate for the idea that these local organizations can and must exist alongside those national or even statewide networks and frameworks. So health data utilities, as mentioned, Civitas is a national organization with many members, including the folks here. We have developed this concept of health data utility in partnership with our members who've been doing this work at the grassroots level. So we have an emerging definition for health data utility, and that is that HDUs are roughly statewide, notice the air quotes there, different for different states, entities that combine, enhance, and exchange electronic health data across different care and services settings for treatment, care coordination, quality improvement, public health, community health purposes. And they really enable specific defined use cases, and CalAIM is one of them, with extra protections to ensure patient privacy and security beyond the baseline level. A little different in a state like California, where you already have data privacy and protection beyond the baseline level at the federal level, but think of this in the national context. And they really should have built on this very important point, existing technical, organizational, and trust infrastructure in states and regions. There's always an impetus at the state government level, at the federal government level, even more, to build a new data silo whenever we need something new. And we say, from all of our experience and all of our members' experience, build on connections that are already there. It's the best, most responsible and practical and realistic use of money and people's time to actually get data moving to improve health. So as I've already mentioned a little bit, Civitas created this framework for health data utility and a resource around the health data utility model. We are still in early phases of health data utility. It is emerging organically across the country, and now we're trying to help shape it to be structured in the way that we all believe it should go. And so we created, with support from the Maryland Healthcare Commission and our National Advisory Council, this issue brief and a framework around health data utility and a maturity model. This is all available on our website. You can access it now. We really encourage people to read it, get involved, and think about how the situation in your state and your work could be affected in a positive way by the development and the growth of health data utility. So just some really brief characteristics around HDU. These are important aspects that we've seen tend to rise up to the top across all the different states and region where HDU is starting to emerge. They need to be neutral and flexible. These generally are generally neutral convener entities who don't have necessarily the option for a financial gain, but they're there to serve their community. They generally serve some kind of state or geography, some kind of connected region. They exhibit cooperative state and local leadership and public-private governance. That means you have governance that has people from the government, people from the healthcare community, people from the public health community, from community-based organizations, different people and entities representing the community that they serve, and they are bridging that public-private gap together. They generally have some kind of state policy lever. Could be CalAIM, for example, could be the data exchange framework, could be something that brings them together and says, we're going to do this thing specifically, and we're going to use policy in a good way to make this happen. That could be a designation, incentive. In some states, could be a mandate, could be a structure, a policy structure like the data exchange framework or TEFCA. Generally is multi-stakeholder, includes community partnership and participation. It has inclusive and transparent governance. Decisions are made in an inclusive and transparent way about what happens with health data. It generally has sustainable financing through a mixture of revenue sources from the state government, maybe from federal government, maybe from Medicare, from Medicaid, from public health, from health systems, different mixes of financing to make it more sustainable. And they also offer value-added services to different entities like Medicaid, like health plans, like others involved. They generally have modular, best-in-class infrastructure and advanced technical services. They can add new modules and add new services as needed. And of course, as mentioned, they have a high standard for data privacy and security going beyond the baseline of state and federal laws. This is to show you that we currently live in a place where we have tons of different networks and governance out there in the world. We have a bunch of overlapping and somewhat related networks right now. And they all have different types of governance models. A regional HIE or an HIO, we have national networks and things like eHealth Exchange or the emerging planned TEFCA networks, the QHINs. We have all payer claims databases. We have community information exchanges. We have various types of networks at the state level. We have local and in California county governance models that are different and overlap in different ways. There's a lot going on here, and there's a lot of places for data to escape or not be connected. And it's a problem. And we see it in California, we see it across the entire country. And that lack of coordination around governance for things that matter for us, health data, is a problem. this shows you kind of the ideal structure where you have an overarching multi-sector, multi-stakeholder governance with the various other networks sort of nested in between. You have that governance model sort of laddering on top of other governance models to make sure that we know what's happening with our health data. This is the ideal state when you have mature health data utilities in a particular state or region. You've got this layered and inclusive multi-stakeholder governance. And just a real quick note on public health data. You may have heard a lot about public health data modernization and CDC trying to bring in more funding to modernize our public health data infrastructure. Health data utilities are a critical bridge between public health needs, healthcare needs, community health, and social determinants of health. This is really important. It's a really important way for states to be involved in that national public health data modernization conversation by taking control of their healthcare governance and making sure they don't build new data silos. No offense to all of my public health folks. I love you, you're working very hard, but it's really important that we don't build new data silos that are totally separate from the data that's already there around healthcare and community health. Let's bring it together and use our data resources together and not build any new data silos. So health data utilities are critically important as well for the public health data modernization conversation. So just again to say, we have a ton of important resources around this that you can all access. They're on our website, no paywall, download them, use them, ask us questions, ask Manifest MedEx questions. They were also part of the National Advisory Council to create these resources. We've got our health data utility framework. We've got an issue brief around it. We have more research around what's happening in each state. And we also have information about the social determinants of health and the work that's happening across all of our member organizations. And then one additional slide, I believe, we also would like to invite all of you to the Civitas Networks for Health Conference. All these topics will be discussed in detail. We have tons of collaborative sessions, so we call unconference sessions, to talk about how you bring together health information exchange and quality improvement work, how you create and mature health data utilities. We have some great public health speakers, including from ASTO, from the CDC Foundation, from the CDC itself, the De Beaumont Foundation, and others. So please consider joining us if this is an interesting topic for you. We've got a lot to offer. Part of the conference is available virtually as well, so please check it out. You can find it all at our website, which is Civitas, FORhealth.org. So that's my brief intro. Some more information here, and I think I'm passing it on from here. Thanks, Erica.
You're welcome, Lisa. I actually, I'd love to ask you a quick question before Melissa dives in, because you have this unique perspective that's kind of national, right? You get to see what's happening in all the different states around HDUs. And I'm curious if you have any thoughts for us on the most common pitfalls that you're seeing where states are trying to create HDU infrastructure. And are there advancements or innovations that you see overcoming some of those challenges that we should be thinking about in California?
Absolutely. So really two things. I think the first thing is expecting a cookie cutter model of fit. The strength of HDU is that it is respective to and relevant to and responsive to the needs of specific states. That's why there isn't one national health information exchange network that works for every single state situation. As you'll hear from Bill and others, there is a lot of really great, very mature work happening around the eHealth exchange, for example, at the national level. And that's been going on for a long time. But that's a different use case and a different purpose than the work happening in states. And so we can create a framework and we can create maturity models and guides and sort of ways to direct states, but we cannot give you a cookie cutter template that you can put on your state. I'm a Californian, as you know. It is a very big state. It is very different in different counties, and the way that the public health governance and in some cases Medicaid governance is happening at the county level is very different than a lot of other states. What's happening in Mendocino County, where I'm from, is incredibly different than other parts of the state. And so it's really important to understand and respect the differences across states, especially one that is as large and complex as California. And we have the same thing happening in New York and in Texas and other states that have really large, complex populations and lots of history. So it's important to make sure that we use the framework and we use the maturity model to build the best solution for each state and try and be as standardized as we can, because interoperability and exchange of data depends on standardization to some extent, but we also have to make sure our structures are responsive to the needs of people in those states. That's the first thing I would say. And then sort of the pitfall side, when you talk about these neutral nonprofit entities, they are playing really important roles on the governance side. And I believe strongly, and our members believe strongly, that it's important to have that neutral nonprofit convener. At the same time, we have to make sure that the technology is best in class, that our data quality is very, very high, that we are constantly improving those things, and also that we are being judged, in air quotes, judged by the state and by the federal government at the same level with the same terms as private sector partners. So when you talk about how data is exchanged, people don't really know this. Generally, the regional and statewide HIEs and organizations who exchange health data at the nonprofit statewide level are subject to really strict and very stringent requirements, data use requirements. They are watching over your health data and making sure it does not get shared with the wrong person. A lot of those requirements don't exist for private sector partners. And I don't want to make it a either or, because these nonprofit neutral entities need those private sector technology vendors and creators to give them the best in class technology to use. But that governance layer is critically important, and we are being judged at a very, very, very stringent level. People should know that these entities are out there working on their behalf. So I think that's the kind of the pitfall of making sure we know which level we're working at and how important it is to be that neutral nonprofit convener governance model.
That's so helpful, Lisa. Thank you for sharing that perspective. And I do think it's also helpful to think about kind of the utility layer, the connectivity, neutrality, and then the amazing things you can layer on top of that through private sector, even for-profit partners. So I appreciate that. Thank you for grounding us in the concept. Melissa, I'm going to pass it over to you now to walk us through kind of another level of detail in terms of maturity, how CSRI has been thinking about maturity, and your experiences running what I would think of as an HDU.
Thank you, Erica. I agree with everything that Lisa said before, and she already reinforced a few of my talking points. So I appreciate the opportunity to join you all today. As Erica said, I'm the CEO of Contexture. Contexture is a regional health information exchange organization that provides health information exchange services in both Arizona and Colorado. As was noted by Lisa, sometimes that's statewide, sometimes there are multiple HIEs participating in a state. So we work with our fellow colleagues at the Quality Health Network, the HIE in the Western Slope of Colorado, and Arizona, we provide statewide services. I also serve as a board member for the Consortium for State and Regional Interoperability that I'll talk a little bit about today, and as the board chair for the Civitas Network for Health. So there's a lot of overlap between these efforts, which I think goes a long way to advance the successful coordination and alignment of all these efforts across the country. I thought it was first, as I was looking through Lisa's slides and all the work that Civitas has done around health data utility, I looked at the HDU characteristics, and on this slide, I put a star next to the ones that Contexture as an organization can meet today. I would note a couple things. I felt I didn't actually think I was going to have stars next to each one, because you're not going to be all the way at 100% when a new model comes out. But in this case, with these different characteristics, Contexture does meet all these requirements. But as we look to actually what the different levels are of health data utility maturity, you're not going to meet all of the requirements on day 1 or on day 180 or on day 365 plus. So just recognize that this is a marathon, not a sprint, and it really does take a while to get here. And there's a lot of expertise around the country, so you don't have to reinvent the wheel. Civitas has a tremendous amount of resources and a tremendous amount of people that are dedicated, very mission-oriented, dedicated professionals that are working to lead this activity day in and day out. And we are all more than willing to help lend experiences, expertise, resources, et cetera, to make all of our fellow states successful. In addition to the work that Civitas has done around health data utility models, the Consortium for State and Regional Interoperability, which is a nonprofit small group of leading health information exchanges, we got together during the pandemic, and we were able to advance some really unique collaborative and data sharing efforts across multiple HIEs across the country. We as an organization feel very passionate about health data utilities. And so CSRI took the first stab at kind of a maturity model 1.0. A lot of the individuals that participate in CSRI have participated with Civitas on the National Advisory Council that Lisa's group had to actually really work towards advancing the framework. And we are very all aligned and coordinated on this. But if you're interested in another resource for health data utility, you can go to the CSR website. It's thecsri.org, and you can see the 1.0 version of the HDU maturity model that was built by the consortium. So you can see here, similar to those different layers of governance and different layers of activity, there's really, as we view it, 3 levels of health data utility. You've got foundational health data utility with robust clinical data exchange, EHR integration, and national network integration, as well as interstate data exchange. Intermediate health data utility with more robust public health services, claims exchange, centralized data aggregation, and advanced health data utility when you're looking at robust research and academic services. You're certified for quality and public health reporting, and you've got centralized data aggregation and patient access. So if you want to take a look at this document, as you look more into these models and figure out what's best for your community, there's a whole table of different requirements. And it's really interesting as we talk about this, because we could probably debate for a while, should this requirement be an intermediate or an advanced? And so we have very lively discussions about this all the time. But it's really something to level set that it is a progression, and you're not going to be the most advanced health data utility on day 1. Contexture doesn't meet everything in level 3. We meet most of the other requirements, and really throughout my remarks today in the remaining slides, I'll give you a sense of some of the things that we're doing in this space to give you an idea of some of the examples that HIEs around the country are doing to advance the health data utility model. This is just a reminder that Contexture came together and was formed as an affiliation and merger between CoRio, the largest HIE in Colorado, and Health Current, the statewide HIE in Arizona. We were about 2 years, beginning of next month, it'll be our 2-year anniversary of officially forming Contexture. And so we've had a lot of work in integrating our organizations, integrating our data, our technology, and that's still an effort that we are advancing right now. But we are regional, and we believe that that regional approach to health information exchange and health data utility is the direction of the future. This slide is a screenshot from our website, so you can always go there and learn more. I put this on presentations to acknowledge that health data utilities, and as you advance beyond traditional core HIE, you're doing more and more things than just core HIE services. And I think a lot of times we think of HIEs that are doing the core stuff plus, but as we started to come together between Health Current and CoRio and form Contexture, we really recognized that as we started to dissect all the products and services we have, that we really have 6 different distinct business lines. So we have all the traditional health information exchange services. We have a whole team and a whole initiative focused in Colorado, but certainly expanding into Arizona, where we do quality improvement and generate electronic clinical quality measures that align with Colorado's Medicaid requirements. We have done a lot more in the data reporting and analytics, dashboards, visualizations, data extracts to look at different conditions. And we have initiatives in both states on social determinants of health. This is an area that's interesting because it goes to Lisa's exact point that it's not a cookie cutter approach. Our approach for SDOH in Arizona and Colorado is very different, and it's based on the needs of those communities in those states. We have advanced directives initiatives in both states. In Arizona, we're actually designated to operate the statewide advanced directives registry, and then we're doing more and more in the public health space, and appreciated Lisa's comments on that. Actually spoke with some public health colleagues last week on a webinar, and really there's a lot of alignment and pushing forward on public health initiatives. I graciously stole this slide and image from our friends at CRISP. CRISP is another regional health information exchange organization, certainly meets many of the characteristics of health data utility. This is CRISP's health data utility roadmap, and I thought it was really creative and really just shows that there are multiple stops on the road to becoming a health data utility. I'm not going to go through every one of these, but I think it's a great visual to show all the things that you need to think about and consider and work through and resolve as a community and as an organization as you move towards being a health data utility. I believe very strongly in collaborative and multi-stakeholder governance. So only added this slide in to acknowledge that there are a lot of different models for governance. This is the one that Contexture has adopted, but we recognized we have a board of directors for Contexture that has equal representation from Arizona and Colorado. But what I recognized years ago is actually we can't have all the different perspectives we need just on the board. And so we actually devised a whole series of advisory councils. We're going to be rolling out a new executive advisory council this year. We have HIE advisory councils in both states, policy advisory council, and then we create work groups from time to time as we need them to advance different initiatives. Because I have said this for many years, if we are not meeting the needs of our community, then I don't really think that we are meeting our mission and our goals as an organization. So we really require and request and reinforce and encourage the participation of stakeholders across the spectrum to advance our initiatives. This is just an example of how HIEs can work collaboratively and successfully with their Medicaid and public health departments. We have strong relationships and long-term relationships with both Medicaid and public health, really in both Arizona and Colorado. But this is an Arizona-focused Medicaid public health HIE-enabled strategic plan that we worked to develop in collaboration with both Access, which is the Arizona Healthcare Cost Containment System, Arizona's Medicaid agency, and the Arizona Department of Health Services several years ago. And we really documented and cataloged over 190 use cases that either directly or indirectly impact Medicaid and public health that HIE can support. And then we had to prioritize those. And you can see on the left-hand side, all the different stakeholders that were consulted to get all this feedback. And we developed out of that a 5-year strategic plan for all the things that we would like to work on between 2021 and 2025, and really advanced all these different initiatives. We have done almost everything that's listed between 2021 and 2023. So we've at least initiated it. And if you're interested to learn about this more, I'm happy to provide some additional background. This is an example. One of the things on I think it was the intermediate HDU level was claims integration and claims information exchange. We are working on a series of Medicaid dashboards with Medicaid claims data. This is the first one that was published, actually utilizes immunization data in this case, but we have 5 to 10 more that are coming, both internal and external versions that are based on claims data. Really cool analysis and visualizations that shows between COVID, emergency department utilization, inpatient utilization, and more, what the trends are, what we need to focus on, and really can help advance policy initiatives, strategic directions, etc. Another example in the area of public health, we reinforce the importance of supporting and collaborating with public health. During the pandemic, public health used a system called Central Logic to do bed visibility. They wanted every hospital to send ADTs with bed data to the state. In the hospitals, we had 98% of all the discharge data in the state flowing through the HIE. And the hospital said, I don't really want to replicate the ADT feeds. Can you please work with, at the time, Health Current? So we worked together with the hospitals, and within 3 weeks, the ADT data that we had was customized and mapped for bed data. And as a result, the state had over 70% of the discharge information in the state was real-time for bed capacity information for patient triage and tracking during surges within the pandemic. And then national COVID-19 dashboards. This is an initiative that was coordinated through the Consortium for State and Regional Interoperability and included data at the end of the day from over 20 HIEs, but really demonstrated we might operate differently, we might have different governance, but we are exchanging core standard data sets, and we can bring our data together, we can centralize it, we can display it. This is all de-identified data in a way that really we already have it available. And I think we're not always the first ones that policymakers and others think of when it comes to national data exchange, but the data that flows through our pipes is really substantial and should be utilized for things in initiatives like COVID or a global pandemic. The last thing just to note is that we have very robust community cares, which is the SDOH initiative, Social Determinants of Health. It's a statewide platform in Arizona. And we also have the advanced, the Arizona Healthcare Directives Registry. Those are just some of the other things that when you have information flowing through for a core purpose, you can reinforce it and utilize it for lots of other things. So this is just how health data utilities can provide additional value across the community. I think that about wraps up my time. So we can skip through any other slides we had here, but with that, I will turn it back over to Erica.
Melissa, thank you for that perspective. It's quite a depth of work that you're doing at Contexture. And I wonder, as you think about the complexity of California, the size, just the sheer geography of the state, and then you layer in the complexity and the diversity of the population, the languages spoken, the different delivery systems kind of at the county level, with which I think Lisa alluded to earlier. Are there lessons, maybe just one or two from your experience across Colorado and Arizona with respect to health data utility infrastructure that you might offer to us?
Sure. I would reinforce what Lisa said around collaborative governance. I think that collaborative governance is critical. I do think it becomes more and more complex. The number of counties, the size of geography, the number of stakeholders you have. So you need to balance the collaborative governance with having at least some initial consistent use cases that everyone can agree on and then differentiate over time. I think the most exciting yet complex thing about HIEs and health data utilities is that you can use one core data set for many, many, many different use cases. That can become really overwhelming because everybody has a new and different idea. And I get really excited when people have new ideas, but you've got to prioritize. And so you need, I think if you could utilize a collaborative governance to say, these are the top 3 things that we know we can all agree on, and it's a major, would bring huge value across all the populations, then work on those first. And then all the different use cases will come as you get that alignment and you get the data sharing foundationally there, you can continue to prioritize over time.
I love that that lesson. It's almost like an iterative and phased approach. I think you're describing. Thank you for that. That's so helpful.
Sure.
Last but certainly not least, I'm going to hand it over to Bill Howard to talk a little bit about how we might think about health data utilities in the context of what's happening at the national level, in particular around the trusted exchange framework and common agreement.
Great. Thanks, Erica. Thanks, everybody. My name is Bill Howard. I'm a healthcare IT enthusiast of about 35 years, and about a year ago, left corporate America to become a private consultant. And I'm also leading the board of eHealth Exchange, which is sort of the topic that I'm going to focus on most of today. So, when we talk about TEFCA, what we really want to do is kind of look at what does the current state look like. And currently, if you look on the left, provider to provider exchange using these national networks and health exchanges, et cetera, it's actually working pretty well. I mean, in terms of acute care to ambulatory care, or exchanging from acute hospitals to health information exchanges, or, to even some of the social determinant of health vendors like a Unite Us or a Find Help. I mean, it's working fairly well if the purpose of use is treatment and everybody's a HIPAA covered entity, and that box is kind of working fairly well. What's not working on the right, where there's roadblocks essentially, is in terms of patient engagement, it's not uniform. You can't easily get your entire record. In terms of health plans and Medicaid, they're really sort of kept out of the big network on the left. It's for payment and operations use cases, there's all kinds of barriers. For public health, and where the purpose of use is public health, they're typically not participating in these networks on the left, or not at the level that they could or should be, as proven during the pandemic. And then there's a lot of, we'll kind of say have-nots, those that weren't part of the whole meaningful use program, where they didn't receive funding to adopt electronic health records, whether it's skilled nursing facilities or home health or, LTPAC or behavioral health. I mean, there really are roadblocks in place. And so the idea of TEFCA is to blow up those roadblocks and remove those roadblocks to allow patients to have better individual access, to allow health plans to exchange for payment operations, to allow public health to engage with these networks. And the one thing I'll say is that we kind of talk about TEFCA, but there's really a lot of policy work that's happened over the last 5 or 10 years, really since the Jason report that came out that really focused on the need for APIs. And so the 2 CMS APIs called out there are really trying to highlight the individual access API requirement that went into place a couple of years ago for health plans. And then the APIs that are being reviewed right now, there's a regulation that is going to support payer-to-payer and payer-to-provider API access. And so when we talk about TEFCA, what in the rest of this talk, what we're really kind of meaning is all of the regulations that are out there that are really moving the whole world towards more of an API first model for interoperability. Going back to the HDU maturity model that Melissa just showed, they talked about a foundational, intermediate HDU and an advanced HDU. On the next slide, what I want to do is I want to kind of position what this really needs to look like. What you'll see there is that the HDUs are on the bottom, or a health exchange, or kind of a developing HDU. And there are many, there'll be many health exchanges around the country, or HDUs around the country. And then on the top, you have different QHINs. And, eHealth Exchange is certainly one of the candidate QHINs, but there are others. There's currently about 10 or so that have put their name in the hat. So there'll be multiple QHINs across the top. Some of them might be, hospital or IDN specific. Some of them might be ambulatory clinic specific, but you kind of can see the lay of the land at the national level, at the QHIN level. But then at the bottom, you can see the local or regional health data utilities that will exist. And there's a whole bunch of things that are just not part of these national networks, or are not part of TEFCA, and will not be solved by APIs. And in the smaller blue boxes are really kind of some specifics that are really kind of aligned with the HDU maturity model, and really aligned with what's necessary. We've talked about local governance multiple times, but what does that really mean? I mean, you got to have, if you're going to use APIs, you need to have some rules around for what purposes will you return what data. So there needs to be really granular data governance and rules that are set for local use cases. There's going to be unique connectivity. I mean, we talked about some of the interesting things that are set up in Colorado and Arizona. There's a bunch of unique connectivity and requirements in California due to all the things that get deployed at the county level. And so there'll need to be those types of services set up at the local level. To get all this stuff to work, you have to have some kind of patient matching, or master person index, or record location service, and then a set of relationships between those. I am a member of this health plan. My PCP is at this provider is part of this health system, and all those relationships need to be instantiated in the system to allow the data to flow correctly. Consent and patient preferences is another one where these are not services, solutions that are part of TEFCA. It needs to happen at that local level where there's trust and local acknowledgement of local policies. Alerts and routing. I mean, these are not things that will be solved at the national level. Providing encounter alerts or providing routing of data is just a huge value that's an opportunity for these HIEs or developing HDUs. And you get the idea. So there's multiple things down the list there. So when we think about all of these things going on with AB 133, with TEFCA, and thinking about how the market will evolve, you can see there's a very clear place for a local health exchange or a developing HDU, and they'll play a really important role as it fits into the national environment and the national ecosystem. So hopefully this helps provide some more granularity and more specifics about how everything will plug in as we move to the future with AB 133 and TEFCA and all these other initiatives. So that's all I had for today. Thanks.
That's thanks for that, Bill. And I love your prior slide with kind of the explosions around the different roadblocks. I'm curious, from your perspective, as you know, eHealth Exchange took many, many years to become what it is today. It has had kind of this evolution over time. And TEFCA is voluntary at this point in time, just like the other national networks. It's more complex, at least in my opinion, than any of the prior national networks that we've seen evolve. And so I'm curious, what do you think, if you had your crystal ball, what do you think uptake will look like on the TEFCA front over the next year or two? And given in California in particular, CalAIM is in motion now. We're just on the other side of a pandemic that really demonstrated severe deficiencies in our public health infrastructure and public health access to data. Can we afford to wait for TEFCA to become the thing that it promises to be?
Mm-hmm. Yeah, well, I certainly wouldn't wait. I mean, these things take so long to roll out. As much as you'd want it to happen overnight, I think we all are realistic. And I mean, just so everyone's aware, I mean, eHealth Exchange was initiated back in 2006, so more than 15 years ago. It's taken that long to really achieve massive levels of participation, to the tune of about 1 billion transactions a month. But it's really specific to treatment and provider exchange so far. And so when you think about even TEFCA, I mean, TEFCA was enacted back in 2016. It was almost unanimously passed as part of the Cures Act and 21st Century Cures Act. It had a overwhelmingly positive vote in both the House and Senate. I can't imagine such a thing. And I think that, given that was a law that was in 2016, and it's now 7 years old, you just know this stuff takes quite a while to evolve and adopt. And so when I think about the timeline and the CalAIM requirements, the AB 133 requirements and timeline for everything you're doing in California, I certainly think it makes sense to try to align with TEFCA and national things, but you obviously have to move full speed ahead with what's happening in your market. And again, I think, just being more specific, I think, if you can try to adopt services that are required by AB 133 and the national markets, like some of the things listed on the slide here in the blue boxes, those will be necessary for AB 133 and the future. So you can really future-proof by trying to keep aligned with what's happening at the national level, but obviously at a timeline that is more aligned with what you're doing in California. So hopefully that helps kind of set the stage and how these things will move forward in tandem.
Yeah, that gives us some food for thought. Thank you for that, Bill. We have about 8 minutes left. And I have a question that I'd like to ask of all of you before we transition to questions. It looks like we have a handful of questions in the Q&A. So again, I selfishly am going to tie this back to California. We have this environment in California where there's a statewide nonprofit HIO, Manifest MedEx certainly serves the whole state. We don't connect all of the nodes and endpoints around the entire state, right? And alongside that, we have many regional HIOs that also connect critical endpoints and stakeholders within their kind of sub-state geographies. At the state level, we have the state government launching this eHealth program that I mentioned earlier, and that will allow both for-profit and nonprofit organizations to support exchange be deemed at the state level. But the kind of tricky part in my mind related to that is there's no requirement for data trading partners to participate in those deemed organizations, in those eHealths. And frankly, I don't think there's a roadmap currently for connecting all of those designated organizations together. So it feels like there's still a lot of fragmentation in the ecosystem in California, kind of no matter how you slice it at this point in time. So I'm curious from your perspectives, given you're thinking about HDUs, given your kind of knowledge base about health data intermediaries and HIOs, your context around national networks, could you give those of us in California one piece of advice, maybe two maximum, for establishing a seamless statewide exchange infrastructure? Maybe we could dare to even think that it might evolve into something that looks like HDU infrastructure as we continue down this path. And Lisa, maybe we'll go in the order of speakers. Maybe Lisa, starting with you.
Yeah, I mean, I think Callie already looks very carefully at equity issues. Think of it in terms of equity. You need to make sure that people in all corners and in the middle of the state are getting roughly the same kinds of data services. It is an equity issue. If you happen to be in one county and you get this incredible service where your data goes everywhere, maybe you think, if you're thinking, oh, well, everyone has Epic. That's not the case. And it's not the case for every provider, for SQHCs, for rural providers, for anything outside of the big hospital systems. And so it truly is an equity issue to think about how you can start to evolve in the direction of health data utility across the state, and think about how you need everyone to play at the same level to do that. That's an important thing to consider.
Completely agree on the equity front, Lisa. Thank you for that. Melissa, advice for those of us in California?
I really was thinking about how in Arizona, historically, we've had multiple HIE efforts, and how in Colorado today we have 2 health information exchanges, and how those relationships have evolved over time. It has been iterative, and I think there's a natural tendency to think about maybe the downsides or how it might impact your business strategy to work together. But if you look at it iteratively and you start working on one thing together and you think about, okay, well, it might impact me in a way I wasn't expecting this way, but maybe there's those downstream benefits to my participants when you have bidirectional exchange between those regional organizations and the state in a way that you weren't thinking about before. And I've thought about TEFCA that way. I've thought about the national networks. I've thought about our relationships with other HIEs. And sometimes if you flip it on its head, you might think more innovatively and creatively in a way that you haven't before. In Colorado, we have built upon, so we had the first use case of how historically Correo and QHN work together. And now we have like 4 or 5 different ways we exchange information. It doesn't mean that we all have each other's database fully integrated in our own data repositories, but there's a fair amount of data exchange that's happening to meet the needs of the community. So I would go back to those 1, 2, or 3 top things that you can all agree on that would advance what's right and best for the community, and try and kind of flip things upside down to think about what might be different than you may have thought about it before.
That's so helpful. Bill, go ahead.
The one last thing I guess I would just throw in there is that, I just wouldn't underestimate the value of some of these core services like patient matching and pushing of data alerts and establishing some type of a consent model that does work across the whole state. And I just think that, to be focused on it as a neutral convener, a nonprofit that has a mission to achieve that, but stay really focused on those core services, because that's really where you can't do it on a national level. And I just don't think the trust will be there to do it with anything but a neutral nonprofit organization. I just don't think the trust will be there. And so I just think that the model that you're advocating, I think is filling a really important core function, and the health data utility will provide a ton of value to CalAIM and all these initiatives. So anyway, it's exciting, fun times.
Erica, can I add one point of clarification? I think it's a little bit, I know there's tons of great questions and we won't have time to answer all of them today. I just wanted to say it's important to recognize that HDU and TEFCA, they overlap, but they serve different critically important needs. And TEFCA and QHINs really have no concept of state. They are queries, they are potentially alerts. They're based on individual requests under the framework, under the trusted framework for specific use cases. And as Bill has explained with the eHealth Exchange, it's taken years and years to get to this point where it's a really functional national health information network. These use cases that we're talking about at a high level, things like public health, things like connecting, community information, those are very far off for TEFCA should the network go live as planned later this year. And so the needs, as we've been discussing, for California and for CalAIM, they're now. And the organizations that are connecting those data sets, they're already in California and in all of these other states that Civitas members represent. And they are doing that work. So it will be helpful in the future to have really functional and well built out TEFCA and QHINs, including eHealth Exchange and others who are on that path. But that is a different use case than what's happening in specific states for specific purposes like public health and health improvement. So I want to make sure people understand they cannot really do the same things, except for maybe an individual query for an individual patient's information. And that's the lowest, that's the bottom of the food chain for health data utilities. They do much more than that. So I want to make sure you understand that they are overlapping, but not the same.
Thank you for that, Lisa. That's such a helpful way to kind of tie those pieces together and help us think about how the complementarity between them. And also, I think the thread that I'm picking up on is the evolution. And our environment is so dynamic, and the needs of our communities are so dynamic, and the more nimble we are and flexible and willing to be iterative with our infrastructure, leveraging both national networks and more local health data utility infrastructure, the better off we are. We are at the top of the hour. There are a bunch of great questions in the chat that we'll take back, and maybe we can do some blogs or find some other ways to follow up on these questions, because there really are some gems in here. I want to thank Lisa, Melissa, Bill, so much for joining us today and sharing your perspective and expertise with us. This has been hugely helpful. I really appreciate it.
Thank you so much.
All right. Take care, everybody.
Thanks, everybody. Bye-bye.